Thank you everyone for joining us, and we are ready to start. I have Noluthando Ndlovu with me. Welcome, Noluthando.
Thank you.
Let's dive straight in. I'm going to let you introduce yourself if that's okay, and
Okay.
Please also explain a little bit more about Health Systems Trust and the division that you work in.
All right.
Thank you.
So I'm Noluthando Ndlovu, and I am the program manager for the research and implementation science team at the Health Systems Trust, or HST, as most people know us. We are a very long-standing NGO working in the public health sector. We do both health system strengthening, but also health systems research, and that's the division or team that I work in. I've been working at HST now for a little over 10 years, so I've been there for a while. But the organization has actually been in existence since 1992, so like at the dawn of democracy. And really, I think just the overall mission of HST has really been around health equity and really trying to reduce inequalities and just make sure that people have better health outcomes in the country. So yeah, our work is very diverse, but generally centered around public health, as I mentioned, but we work with diverse groups, and really at the center of it, some of the things I'll be telling you about are some of our flagship products, which are the SHR and the District Health Barometer, because knowledge production is also one of the key things that we've done consistently across the 30 plus years now. So I live in Durban, and I work in the Durban office at HST. We do have offices in other parts of the country. Originally from Pietermaritzburg. I'm a mom and married as well. And yeah, I think that's the long and short of me and HST.
Thank you. HST, it's not a state institute, it's not a university, it's a non-profit.
Yes. And I think that's the thing I love about the uniqueness of the research environments that I work in, because we really do work at that interface of policy and research and data. And I find this ecosystem quite unique and environment unique because a lot of the work that we do actually is used to inform policy for the country, which is very important. So, we generate evidence that really drives evidence-based decision making, with a lot of the data that we collect, but also the data that we have from our routine systems. So as a nonprofit, we're not quite like a full-on academic institution like your universities, traditional universities. So even the research we do is not really traditional in that sense. But it also allows us and gives us that room to really do research that can really be informed about what we see in the programs within the programmatic work that HST does. In some of the biggest programs around like HIV, for example, we have our SHO project, which is one of our biggest projects that is actually on the ground, but also things around like NCDs with cervical cancer, for example, and other different areas. And very excitedly also moving into climate driven and environmental drivers of health. So we've doing work now in air pollution space and also climate change space. So it's evolving, and I like that because we're able to really touch on a breadth of different areas as an NGO doing traditional research, but that's also very much informed by what is happening on the ground.
Okay, thank you. That's a lot of information.
I know.
One thing I would like to ask, and I don't know the answer, but I think a lot of our audience doesn't know either. So in a classic university, you have faculties, and then within faculties, you have departments. And each department typically has a mandate to teach and to do research. But at HST, there is a dedicated group that is focused on research and implementation science, which you're part of. That suggests that the other divisions or departments, I'm not sure how you call them, don't then have a research core unit inside of them, and they depend on support from the RIS.
Yes.
Is that correct? Can you maybe explain a bit
how
more?
How we're organized.
Yes.
Yeah, sure. I'd be happy to. So we have our units or departments, but generally when I explain to people, I say that we've got our implementation side, And with our implementation teams, they like direct service delivery type of like services. These are your clinicians, people who actually work in health facilities. So when you walk in a South African health facility, you might very well find, particularly in the districts that we support, because it's not the entire country, but like 4 focus districts, for example, in KwaZulu-Natal, or like Ndlovu, eThekwini, uThukela, and Zululand, and you might very well walk in and you find an HST employed, like nurse. But so we have a lot of that on the ground experience. People also are doing very like much community-based work, psychosocial supports in terms of like supporting pediatric, for example, HIV, and that's our sort of like health system strengthening unit or team. Then we have the research team that really focuses on the research and implementation science. And the implementation science actually is a new development within HST. We used to just be called health systems research. But over time, we've sort of seen the evolution of how much or how important it is for programmatic work or programmatic like systems to actually inform the research that we do, and as much as possible try to work in partnership so that if there are gaps that people are seeing in terms of like the experiences that they're seeing in the field, with the communities, with patients, whatever different type of aspects, because as you know, health is so like multidimensional, lots of different contexts, lots of different areas and things that feed into your well-being as a person. And so us having that programmatic side to also inform what should we focus on is also very important, because then you're just doing research for the sake of research. And so we have that health systems like research team, which is now called the Research and Implementation Science team, which I work in. And then we have like our support system, which is like our corporate services, our IT team, our human resources team, our communications team, because comms is also a very important aspect of the work and health, that we do in terms of like knowledge translation, for example. So that's like pretty much how we're organized. Yeah.
Okay. And as the name implies, Health Systems Trust, all of the research, all of the focus is health related?
Yes.
Which brings me to another question. You didn't study medicine or biotech or nursing. Can you tell us a little bit more about what you studied and how you ended up working in health?
Sure. I like to think of myself as a little bit of an anomaly in the public health space, because I didn't do an MPH, as you know. I did environmental science and geography, and most importantly, majored in Geographic Information Systems, which is GIS. So with that background, thinking about geography and location and how contextual health is. Geography and GIS overall, for me, I could have literally worked anywhere. But when I was doing my master's, I got a great scholarship to work on a project where I was mapping malaria, doing spatial epidemiology, studied a little bit in Switzerland, and then came back to South Africa. And that experience really then opened up my mind to public health and how like those environmental drivers of health actually can inform health outcomes, how much your location determines so much, about a person. The fact that we're currently sitting in Cape Town, being in Cape Town, I can just based on your location, there are so many things I can tell you about, for example, your health outcomes, your health access, for example. So that's where it's sort of like, the love of like merging those two fields of geography and health really came about. And just maps, GIS, we make maps, and the simplicity of communicating information in a picture. I can give you a table of data, you can switch off and not want to engage. But when you see a map, it's just a picture. And then immediately with the map, you'd be able to see inequalities, you'd be able to see disparities or similarities and be like, oh, those two districts or those two areas look similar. Why? Or why is that clearing like data point standing out, or that particularly, location looks different from all the other locations? And then you start to interrogate and dig deeper. So, so now I'm in the health space, and the amazing thing, I'm calling it a full circle moment, seeing how much the environment and climatic factors are also not getting attention in the health space globally. So now we're doing more climate change work, as I mentioned. We're also working with the Clean Air Fund, and we're working, for example, on a project on air pollution in Johannesburg. And that's something we probably might not have done in the past, but now we're actually able to do that. We've also done some work in climate change, and I think increasingly we're really wanting to expand in that area because, well, yeah, we're sort of living with it now. Yeah.
Okay, so you would say that the health field has a stronger and renewed appreciation for geolocation data and for maps and for location and those contextual factors. I imagine that when you were studying geography, data was quite a core element. You can't study geography data free. And when you talk about making maps, a map is made out of lots of little dots that are connected. So any GIS data set by design is quite a heavy one. There's a lot of data points captured into a single map.
Yeah.
Is that also the explanation for your, let's call it, bias towards data science and appreciation for data science?
Yes, definitely. And it feels like the data science field, which I think also similar to climate field, is also gaining a lot of traction in the public health space because people are appreciating so much more the value of using evidence for decision making and seeing and integrating different data sets. In like a map situation, we call them layers, and we would have layered all the information to try and get a picture, doing spatial analysis, for example. But data science now is a whole other field that's really also doing exactly that, but using such more sophisticated analysis and, really providing ways in which we are able to interrogate the information, look at the different data sources that you have available to you to get insights. And that's the thing, it's about insights. You can have a lot of information and still not know what's happening. People have access to data or have access to information, but what are the insights? What is the story that data is telling you? And that's what I love about data science and actually thinking about it now, the layers that we have when we're making maps in GIS. That's, a very much more sophisticated sort of version of that, and really getting to interrogate, the information and the key insights, because that's the value. That's how you put out the value, and data science is able to do that. So my bias towards it, I guess, is really the key in which I feel like, it's just obvious.
Thank you. Before I continue, I wanted to say to the audience, if you have any questions, can be clarifying questions, if you object to anything, if you want to ask any question triggered by our conversation, you're welcome to post them into the Q&A section on Teams, and we will then go through those in the last 15 minutes or so of the episode. Okay, so you already alluded to the idea that data and information and insights are not the same thing. And so also I would agree with that. And so a lot of the work in data science is to move data from raw and not usable to a more refined, curated, helpful, useful, insightful piece of information.
Yes.
And so that's kind of the process that a data scientists care about. Is there's way too much data points. I can't communicate in a 200-dimensional space. So I need to simplify it without losing the key, as you call them, insights. That's where all the intellectual effort goes. When we were discussing the topic of this podcast, but also in our work together in the past, one thing that has struck me is that, so I'm an academic by heart, and that's my background. I was a researcher at Stellenbosch University for quite a few years. And my personal experience is that typically researchers really want to be publishers. They want to do the analysis, they want to keep the data to themselves if they can. Now, I think for good reasons that's harder and harder, but if they had a choice, they would be hesitant to share data. They want to do the analysis, say, here's what I found, get it published, and then sort of build their career from that. And what struck me is that the approach that you and your unit, and by extension HST, has taken is to say, we don't have to be the star of the show, we don't have to be the author of the paper. If our job is to turn this raw data into usable information, then others can be the stars and they can publish and they can maybe add insights that we didn't see or we weren't even looking for. So you're more of an information broker than you are a analyst or a scientific paper producer. So I think that's noteworthy. That's kind of different from the general traditional approach to research. Can you speak to that? What explains it? Is it different incentives that drive different behaviors? Is it just intrinsically different motivation? How can we understand this?
I think just it's something I've learned being in the organization, which is HST, over the years. HST has always been a knowledge broker in different ways. And, we have these two flagship publications. One of them is the District Health Barometer, which is one of our data-driven products. But we also have the South African Health Review, which is more of like the commentary and peer-reviewed journal. So two pieces of products, or two products actually, that have produced insights in different ways. And that's always been like the power and sort of ID or something that where people identify HST as being a knowledge broker. So, starting a career in that area and also being there for such a long time, I've also attached a lot of value, and I think it fits in nicely with my geography background as well, in that, providing evidence so that people can actually make decisions that are informed with the correct information. So we actually are more concerned about why are people not using, if they're not using it? Do people know about the District Health Barometer? Here's the book, here's the information, here's the data. We take the raw data, for example, in collaboration with the National Department of Health, using routine data from our District Health Information System. We take that information, we synthesize it, and we package it in a way that makes it more accessible, publicly accessible as well. So there are no paywalls. We have our dashboard that our Wimmy assisted us to build. That was like a big thing for us, because traditionally, like, the District Health Barometer was like a PDF, over 500 pages, because we cover the entire country in the publication, 52 districts in the country, a little over 200 local municipalities, and over 30 indicators are represented in the publication. So you can imagine the depth and density of that information. And then, we really wanted to take that, okay, fine, we've had this book and people are engaging with it, but it was thick. Right? How do we make it even more accessible? So we are always concerned about how do we make information even more accessible, because we want people to take the information and generate even further insights from what we might have presented in the publication. And then we launched the dashboard in 2024, the interactive dashboard, publicly open. People can access it on different devices. Again, you remember when we were building it, like, how do we make the functionality even better? How do we make usability, in the design? Very important, because we're trying to make this thing accessible so people can come back. You don't want to have a bad user experience and then you're like, it was slow. Our dashboard is not slow. It's fast, and people comment about stuff like that. So building those things, and how do we continue trying to make information more accessible. Now we have infographics as well that we are producing now. Again, another avenue of taking the data, and presenting it to people, the public, different stakeholders, use our information. District managers being one of our key stakeholders, because we want them to look at the data and use it for to make decisions in their everyday work. But it's always been a thing for us. Even the South African Health Review, there's no access APC fees that you pay to publish in the SHR. And in the publishing world, how the article processing fees now are just astronomical in some publications, but our journal is still free. People still publish in it freely. And again, a different type of information is synthesized from experts in the field, just commenting about different areas of our public health system. So we are knowledge brokers, I think, first and foremost. And then we became other things along the way and developed other strengths as we did the health system strengthening areas that I mentioned before. Yeah, very long answer.
You've spoken about the District Health Barometer. Another product we worked on together is DataBridge 360. It's not the same.
Yes.
There's some similarities in terms of the approach and the intention, but they serve different purposes. Can you speak a little bit about DataBridge?
Sure. Yes, so DataBridge for us was, again, just moving a little bit of a step further by also trying to build something to really, again, try to provide information in one place for whoever wants to access it, the public, policymakers, but also other researchers in this space. And that was particularly hard in terms of the design, because trying to design something that will resonate with the researcher who's technical, right, and will quickly understand a very complicated graph, versus the policymaker who really needs information very quickly and doesn't have time to just be going and pouring through a PDF or going through lots of websites just to get the information they need, versus the public who might be consuming information for different reasons. So we wanted to do this, and this was with a grant that we got from the South African Medical Research Council via the Grand Challenges program, where we wanted to build something that, again, could have touch different audiences, but also not just data. It's also got, information in the form of like literature and articles, and also like videos, so that rich multimedia content. So that process was also unique in terms of its design and trying to find a way in which you can bridge that gap of data and knowledge and access to information, the right information. Because there's a lot of information, but as you know, in the field of misinformation lately, there's also a lot of wrong information.
Another observation from working together for the last 2.5 years or so is that even though Wimmy calls themselves data scientists and HST is a health organization, to build a product like the District Health Barometer or the DataBridge 360 requires more than 2 skills. It's software engineering, it's data engineering, it's cloud architecting, it's analysis. It's, of course, also a lot of subject matter expertise, because if you just have a data scientist who knows how to wrangle data but doesn't understand what it means or what is relevant and accurate versus noise, then you're also wasting a lot of energy doing irrelevant things.
Sure.
So I'm bringing that up because I think you are a good example of somebody who has to, as a manager, has to have a handle on how to bring people from different backgrounds with different skills together and manage them as a team and say, together we're going to build this product. We all have our strengths, we all have our blind spots, but together we can do that. Yes. Can you speak a little bit about the opportunity, the challenge? What have you learned along the way?
Yes, I actually think just by nature and the fact that if you think about the contextual aspects of health, it does require a multidisciplinary approach. And so, we never used to have data scientists at HST. It was something that we introduced, seeing, for example, a gap of us when we're trying to, create this bridge between the data and the insights and the knowledge, and then also the knowledge translation. So, but also, as you mentioned, having to work with different disciplines in order to get the complete picture of the issues really that are still very challenging that we're trying to solve. So I feel as though we've also been able to do that quite well at HST with our collaborations, and knowing that we don't have all the answers, but we're able to bring in the expertise as we need to. And this, we have evidence of that in terms of our collaboration with Wimmy, where I had something in my mind of what I wanted to do, but I didn't cloud architecture and all these other things that were required to bring the dashboard, for example, to life. Again, being able to be like, hey, so this is the idea I have, and we sort of had the sort of expertise in terms of like the public health system, but also the uniqueness of Wimmy was that you guys also have health backgrounds, and I think that's a huge positive. So that was also another thing that sort of attracted us to being like, hey, we want to do this, but want to do this with this particular set of people because of that context. So us being able to draw people in as and when we need to is also really great, because we do work with a diversity of stakeholders, like the National Department of Health, the provincial departments of health, and even the district level, what our key stakeholders in terms of enabling us to do the work that we need to do. We also work with universities, so the academics as well. And it brings in all the different sort of like strengths that we don't need to have everybody sitting there 24/7 at HST for 12 months in a year. We can collaborate and, draw on different strengths, when we need to. So it's been, it works quite well. There are challenges in everything. Group work is always going to be challenging. And I don't think it was group work in high school, group work in university, and even in like the work setting, it's the same thing. And there's always going to be different challenges based on time and priorities and other things. But more than anything, I still go back to that model of working, because the benefits of it have so far outweighed the negatives of trying to do everything ourselves. When different people can come in and bring in, elevate what you already know. Yeah.
Okay, great to hear. On the topic of managing and stepping back and realizing I can't do it all myself, but together we can do it. You started your career as a researcher, where you were in the driving seat and you were writing the script to analyze the data. Mm-hmm. Now you manage and supervise others who are writing scripts. Can you say something about that transition? How did it happen? Did you have any mentors or any guidance? Did you do any courses? Because management is not something you learn at university, typically.
Yeah, true.
So I think a lot of people, especially younger people, it might be quite daunting making that step from researcher to research manager.
It's been interesting, and I think it really challenged me to grow. First of all, managing people is a very steep learning curve, because people are so different and people are so diverse. Working with data, it can be so simple. You're just interrogating and working with your data, and whatever it tells you, the issues that you have are technical, and maybe you can't figure out something, but eventually you will. Working with people is taking those diverse data points and multiplying it by I don't know how much. But I think the transition also was just gradual in terms of that, starting out, as you mentioned, as a researcher, but also consistently working on the District Health Barometer as a data-driven sort of project. It's important. That foundation was important, because even now, as a manager, if somebody has a problem, it's not something I don't know about or I don't have context about. I have a general idea of, actually, this is what could potentially be the issue, because it's something I would have also generally encountered myself. So I'm able to provide both the technical sort of like understanding, but also just the the level and experience of having to interrogate and interact with a diverse group of people. So it's a skill on its own. Didn't go to school for it. Maybe I should have. Didn't go to school for it. And I still feel like it's an area I'm still developing and still learning. And I think you learn forever, to be honest, because you're always going to find, just different people to work with. But I think I really value the fact that I have the technical knowledge, even within the space of also now helping others to learn and able to share what I know and help them learn and grow in a particular space and adding context, because chances are, like, I've been there, I've gone through that process. I know what issue you're potentially talking about, and I can try to provide some solutions. So yeah, it's a developing area, still growing and still learning. But what is that? There's a phrase that says, "Don't about humble beginnings. You must always value, or don't dislike those humble beginnings," because it helps you just go through the whole transition. I was a research assistant before that. I was a data collector before becoming the research assistant. So having to transition throughout the spectrum of research really helps to provide the context. So when I send a data collector out, I'm not just being random about it, and they have issues, I can relate because I've done it. Similar with the data and the technical stuff. Sometimes people will ask you for things, and because they've never done them, it will seem like they're asking for, credible things, but they're not. So,
I want to try and take us back to the topic of the episode and speak a little bit more about the actual data science. So, as a researcher, you typically know, or you have a sense of, I think I know how to do this, and then you just dive deep in and you get your hands dirty, you're writing code, you're moving data, and even though you might be using best principles, it can still be a slow and manual process to go fetch data somewhere, interrogate it, do quality assurance, try to clean it, do the analysis, and before you know it, many months later, you finally have an answer. And then the problem is sometimes somebody says, "Oh, good news, we have an updated data set," and now you have to retrace your steps and do the whole thing over. At some point, you realize this is not a viable thing. We need to automate this whole process, and we need to make it less of a manual process.
Yes.
I think as a researcher, that's less likely that person says, "I'm not doing this anymore. I need a machine." But if you stand back and you say, "But now I've paid you 3 months, I'm not going to pay you another 3 months to do this exact same thing." That's where the drive, so inefficiencies drive innovation. And I think as a research manager, when you see an inefficient process, you go, how can we optimize this? And so some months ago, you came to us and said, this manual process, can we replace it with an automated one? So my recollection, but I want to hear your perspective and your experience, is that we took something that took 3 weeks and replaced it with an automated process that took about 10 minutes to complete. That's my... That's the bottom line, but I want to hear your version of that same story, if possible.
Sure. So if you've seen the District Health Barometer, like I mentioned, over 500 pages. At some point, we're actually reflecting about this at work just yesterday. At some point, 1,000 pages was a 1,000-page book. And there was actually a lot of manual things that actually went, into it. As I mentioned, we use different data sources, the routine data systems, but also information from National Treasury for our financial indicators and our human resources indicators that would require us, in order to code it to like facilities and then get the district, would take like weeks to do because of just the process and having to comb through all those all those different records. And so having to do this every year, I think now the District Health Barometer, it's in its 18th or 19th edition, so 20 years later, of having to, repeat the process, but also having people that have worked on, like some of the pioneers of the District Health Barometer, Caddy Day, Peter Byron, some of the people that have worked on it. That foundation was also, incredibly very strong in terms of just getting that process to be there in the first place, but seeing, okay, how can we now take what has been there and try and make it, more automated. And not just that, also sustainability is another part of it, because at the point also when you're doing manual work, it also sort of means that it's a process that the person, has to go and do. And having to then manually teach someone else, okay, so this is how we clean the data, this is how we do this is how we do that. And so I just, when I reached out, I was like, I need to find things to make sure that things run, so that every time I interact with, I'm like, what did I do here again? How did I do this? So how did I do that? What was this, that type of process? Not having, I didn't want to do that anymore. Not even not wanting to do it. I didn't have space to do it anymore. So then, step in, Wimmy, Emmanuel, and having to hear him saying that we used to clean a data sort of set for 3 weeks, give or take. And then he's like, he did it in 10 minutes. I was like, what? Using, the scripting and the programming and the Python, my mind was, blown. But investing in, that process for me has been so important. Also, the sustainability aspect of it, but also the efficiency that's now been created to free me to do other things, and free also the data scientists that we work with to do within HST to also focus on other things and not painstakingly clean data or download things manually. The list goes on. And now having those data pipelines in place for the production of the barometer, I think without going into all the details of how we get from data to the publication, it's a lot, it's a lot. And having those steps now automated and spending that process last year doing that has, I think it's just going to increase our efficiency so much more for us to do other things and focus on how else do we make it better? What else can we do? And not get bogged down with data cleaning and coding.
Yes. So I think that's an important point, because it's not just about saving time and money. It's about that saved time and money can then be reinvested and repurposed into tasks that are intellectually harder, that are more creative, and that you can't as easily automate or outsource to Python or a large language model. Okay, great. I think we are close to the end of our conversation. Maybe just to round off, the theme is the uniting power of data science. And I think HST as a whole, and your unit in particular, are a role model for an ally, a partner that at their core is a team player. And I wonder if you can say a little bit more about the various teams that you have played in. So we are a private company, we work with a non-profit, but you also work with other private companies, you work with other non-profits, work with international donor organizations, with the government. That's challenging, but it's also incredibly enriching, and some of the work couldn't be done unless it was in this multi-stakeholder ecosystem.
Yes.
So maybe just your final words on that, and then we can take the questions that I think have been pouring in.
Sure.
Thank you.
I think just reflecting on, I was seeing an article the other day saying it's actually been a year since that big US aid and US funding cut happened in the country, and it shook up a lot of things. And I think just the global space of funding in particular is really now more than anything like demanding that we work collaboratively and we work as teams, and also the multidisciplinary sort of nature of public health and seeing the strengths of actually tapping into different areas. It's very difficult in one organization, maybe in a university setting because it's all the disciplines, but like in an NGO, to find all the different disciplines represented within the organization. So how do we now, work with teams and collaborate with teams where they have certain expertise in those particular areas, and not just the discipline, but also as you mentioned, the different sectors as well is very important because, as a private company, the way in which you work, for example, will be very different, but also you're exposed to other things that as a nonprofit, we wouldn't be exposed to. And also the level of maybe like the tech that you're able to get access to and you can use are things that would not be within our reach in a nonprofit space, for example. Similarly with the traditional academic settings as well, being able to tap into that because they still do the very much like very highly scientific and traditional research, and able to tap into those expertise is also a very important thing. So I feel as though we've been doing quite well in doing that, but also working with the government in they provide the services, the majority of the services in our country, and we're always striving to see how can we collaborate with them, how can we work with them to ensure that they're able to help better and do more and better in ensuring that the health outcomes of South Africans, is better. So I feel as though, the place we find ourselves in sort of demands a teamwork, and we're able to convene people and able to bring together people that have the right expertise. And it's also one of the key strengths of being in the space that I'm in.
Great, thank you. If I may add to that, I fully agree with everything you just said. Reflecting on my own journey with Wimmy, imagine that we only served commercial clients. I think our behavior, our mindset, our approach would be different.
Profit-driven only.
Yes. So some of our clients and partners are academic research institutions. Some are non-profits. I think HST is a hybrid of both. And then we also have private companies as our clients and as our partners. And the mindset, the priorities, what is valued, what's not really important, varies. For a scientific institution, it has to be publishable in a peer-reviewed journal. It doesn't have to necessarily be super fast. So we want the deepest, best answer, even if it takes you 4 months. For a mining company, we don't have 4 months. We need an answer tomorrow. And if you don't have a confidence interval around it, or it lacks a p-value, that's fine. We wouldn't know what to do with the p-value anyway. So just give us an answer. And so from our side as a consulting firm, that's challenging, but it's also enriching because we can take some of the learnings from one type of partner and we can sort of help another partner who maybe hasn't really viewed the problem through the lens that a private company would have viewed it, for instance. So thank you so much for this very interesting conversation.
Thank you.
I would like to now go through some of the questions. Most of the questions I think have been posted on the Q&A, but I see there's also questions in the chat, so let's go through them. First question is, how does HST presence in selected KZN district assist in KZN in informing policy and system strengthening? Is there any observed advantage which could be replicated in other provinces?
Oh gosh, great question. I think I should have also qualified with that, with the selected districts that HST works in. is particularly for our health system strengthening project, the SA SHOW project, which is focused on strengthening the HIV response in the country. But however, the research we do actually is not just limited to KZN. We actually do it across the country. A couple of our projects have been national projects where we've worked with the National Department of Health to assist them also with policy and evidence and understanding the context of the problem. So we've worked in all the provinces with our research in particular. And as I mentioned, with the District Health Barometer, it covers all 52 districts. So I think possibly the value that is that the teams that work in those areas have a little bit more context, us being in the same organization and leveraging on our understanding our strengths. And even when we write our reports at the end, we have meetings with our programmatic teams to be like, hey, so this is the information that we found when we were doing our research. Does it track? Is it consistent with what you've seen on the ground? And that further strengthens our research process by having that sort of content validation, sort of like interaction. So I think that could be like the key thing in that we should not see research and also the direct service delivery as two separate things, but through implementation science, really trying to close that gap, the no-do gap, as they call it in knowledge translation, of knowing and generating the evidence and then actually doing. Now you know, how do you do better for better programmatic and health outcomes? Yeah.
A related question is the District Health Barometer and the Health Systems Review. How have they influenced delivery of health services in districts? Are these publications still relevant? Are there ways in which they can be made popular among health systems officials in the country? And at what point are these publications going to be inclusive of private sector? That's a lot of questions. Then another one is, what are your thoughts on the extent of the quality of data from the DHIS and as it informs your publications?
Gosh, that's a lot of questions. Who wrote those questions? I'm joking. So, like when I said to you that as knowledge brokers at HST, we're always so concerned about how do we make information more accessible. What are the key things? If when they ask you the question, what keeps you up at night? That's something that keeps. Are people reading? Are people engaging? Because there is so much data, but are people actually using the information to actually make better decisions? And it's not as simple as you think. Sometimes we think that people just need to be given the information, and then suddenly, you have all the information. You're gonna make better information. And we know from behavioral science that it's not such a simple thing, but we're always concerned with the fact that people need to have information and they need to have the correct information, and having experts in the field also interacting with our data helps to provide context. So the chapters, for example, in the barometer are actually that we give authors data and then they actually interrogate the information to write the chapters. So it's a big ecosystem of different stakeholders actually contributing to providing that context. And data quality with routine systems, I think, is just an ongoing issue that we contest with. And I don't think it's unique to the public sector. I think private sector also grapples with this, and something I'm sure you found even when working with the mining companies and having to now be confronted with actually the quality of the information that you're getting. It's always going to be a constant thing that we sort of grapple with as we try to, make our systems and information sort of better. So I think these two publications still very much relevant because, like I said, the SHR, that's a different set of or type of information because it's commentary, it's policy analysis, really looking at the landscape of what is happening in our country and providing, really rich context through research, case studies, and other experts. Currently, the publication that we're working on, for example, is learning health systems. And that's always going to be something that's important, that people can know that when they go to the SHR or the DHB, you'll find the information. So, yeah.
Thank you. The question about at what point are these publications going to be inclusive of private sector? I think, well, there's a few possible answers. A simple one is when NHI actually is there and is fully functional, because by then,
data sets.
Presumably private sector and public sector are working very in a very integrated way. That's one answer. When that is, I think no one knows. But another answer would be when there are synergies, when they need each other's information. When private sector says, we don't want to just analyze our own data, we want to blend it with public sector information and vice versa, because these two data sets together give us insights that the two separate can't give us. And now there's a reason to be more inclusive. And then a third answer would be when there is also more trust and more understanding.
Yes, more trust, more understanding. And I feel like COVID showed us that, that is possible. Yeah.
Okay, last question, I think, on this, on the chat before we go to Q&A. Any interesting ways the organization guards against reinforcing existing inequalities when data availability and/or quality is uneven across regions or populations?
Oh, reinforcing inequalities. Gosh. Yeah, no, that's a great question. And I think, there are so many different initiatives that, we also do capacity building, by the way, as a health systems trust. It's something I should have also mentioned, and also technical assistance as well. So I think within the teams that, work at HSC and with our capacity development unit, we're always trying to capacitate the people working in the ecosystem. So providing also the TA in terms of how do we improve data quality, and also interacting in different spaces with those different stakeholders also makes a difference. So we like questions that we will ask is, why are people not using the information? Do the data collectors or the data captures in the facilities maybe not fully understand why they're collecting the information? So by the time it filters up the chain, the reporting, you're seeing funny data, and then why doesn't that person care? So I think without different engagements within the different stakeholders in the ecosystem of the public health space, we do try to strengthen where we see gaps through capacity, development, wherever opportunities do avail themselves. Yeah.
I think the other method or way in which the analysis is somewhat protected against reinforcing these inequalities is by having a very strong focus on granular data.
Yeah.
So if everything was aggregated, then there's this big risk that the districts with the highest quality and the most availability are dominating the narrative. But by saying, well, you can drill down from province to district to sub-district, if a sub-district doesn't have enough data to be published, it will show. And
that's
so
true. That's so true. Yeah.
that shows the inequality rather than masks it.
Hide it, yes. Yeah.
Okay, let's go to the Q&A. We have a few more minutes. Okay. When looking at the data sets that HST compiles and the geographic parameters, are there any trends or insights emerging around the impact of climate change?
I think when I mentioned the fact that we're really trying to be intentional about doing more work around climate change and health, and just climate and health in general. So we did this through a chapter that was written by a group of colleagues led by Carrie Wright, where they wrote a chapter on climate change and really trying to see which indicators could potentially be measured within our health system. So that integration has not fully happened in terms of looking at which different indicators are actually driving possibly like the climate-driven health outcomes. So it's a space that's still developing and is not fully, I think, has not fully emerged yet, because we're still sort of interrogating and engaging with what is actually happening on the ground and how can the health system respond, and which indicators do we need to track and look at in order to be able to provide those responses. Yeah, we just see a lot of flooding. Just speaking about KwaZulu-Natal, we were speaking about it during lunch actually with one of your interns, about the flooding we're seeing in Limpopo and in Mpumalanga at the moment, being exacerbated by climate change, and also seeing how those impacts are actually going to be, fall over into other areas, apart from the health outcomes, but also the people working in those spaces and getting access to health facilities, for example.
Yeah, so I think there, even though climate change is a slow process, it also manifests as sudden bursts.
Yes, extreme
weather events that then lead to disasters, floods and droughts and so on. So I think the key will be to have data that's detailed enough in terms of space and time to see those spikes, and not have this averaged out over a whole year, because then we might miss the effects.
Yeah, and also just, I think, more real-time, whatever that means, real-time data or more near real-time data sets available for people to be able to react and plan better.
Last question. How do we account for issues related to data stewardship, accountability and ethical research when implementing automated research processes? Okay. Very good question. I would say they don't go away. In fact, they only become more important. So if you say, I'm not going to do this as a human, I'm going to write a script that does it automatically every morning at 4 a.m., then it becomes more explicit. And so who wrote the script? It's not a question. We know exactly who wrote the script. Who gets access to the data? That's also hard-coded into the whole system. Of course, ethical research. So is it ethical to ask this query, or is it ethical to publish this result? That, I think, stays the same whether or not the results are produced by a human or a computer. But because it's now more programmatic, it's easier to track what changed, who changed it, why was it changed, when was it changed. So I think it's actually, there's more synergies than conflicts with principles of data stewardship and accountability.
Yeah, couldn't agree more. I couldn't agree more, for the very fact that I don't think the human is ever going to be removed out of the process. Even with the implosion of AI and all the different ways in which it's being used, our knowledge as experts is still going to be the key thing that is important, even when engaging with those processes. There are certain things that you needed to know to be able to write the script that you wrote in the way that you wrote it, with the context. When you decide that the data actually needs to provide this type of output, it's informed by your knowledge. The script or the automation didn't happen in isolation or by magic. It was informed by a process. When we said, actually, this coding, when you see this, it actually means that. That's always going to be there. It's always going to need your expert insight. And I feel like you can never separate the two.
Yes.
Actually.
100%. And maybe as a closing remark, any script you write is written in the context of a project, and that project has a scope, it has a rationale, it has what are the success metrics of this project. So it's not just
random
in the middle of nowhere out of context. Also, good scripts have documentation built into them, so you can follow along. I'm doing this because of that reason. And so even when there's no humans involved in the actual execution of the process, there are still human language documents that you can trace and sort of understand why the thing is doing what it's doing.
Exactly.
with that, I want to thank everyone who made time to join us for your time and your interest. And next month in February, we will have another episode, and we hope and plan to have a steady cadence of once a month. Thank you so much, and enjoy the rest of your day.
Thank you for joining.
Thank you so much.
Thanks for having me. Thank you.
Bye.
Bye.